then we will.
Okay.
Yes, sir.
Shall I start?
Yes, sir. Please, sir.
Okay. It is only a repetition of what I have uh, talked last year, and it is regarding ward rounds. Ward rounds is important in national board exam because it carry around 40 marks, and the student can easily get 30 marks out of it if they perform well in the ward rounds. These are the usual things that are there in the ward. What I'm going to show you are some of the things that are rare, which may be rare in some big hospitals nowadays, but they have got some history behind it. So one important thing is the spring like this will be kept, and they will be you will be asked to identify the splint. So the name of the splint is Thomas splint. Then you may be asked to give the full name of the splint. That is the Thomas bed knee splint. And the original indication for using the Thomas splint was in the treatment of, or what they say, the ambulatory treatment of diseases of the lower limb, especially tuberculosis of the knee. So then they may ask you something regarding this man who is a great man, Hugh Owen Thomas. Hugh Owen Thomas is considered to be the father of orthopedic surgery, and he was born on 23rd August 1834, and he passed away in 6th January 1891, and he discovered the splint in 1876. He used it as a knee appliance for ambulatory management of knee joint inflammation. Then the other questions that may be asked are the degree of inner sidebar to ring, that is this angle, is 120 degree. Then how will you measure the size of the ring? Suppose a patient comes to the casualty and you are sitting in the casualty, fracture shaft of femur comes and you have decided to immobilize the fracture in a Thomas splint. In most of the olden hospitals, there will be a splint room. You will have to take measurements from the patient and go to the splint room and select the ideal Thomas splint. So the ring size is the oblique circumference of the thigh just below the gluteal fold plus 2 inches for the swelling that may occur in the fracture. So the oblique circumference of the thigh just below the gluteal fold plus 2 inches. And the length of the splint is usually the crouch to the heel plus 6 inches. Okay, then it can be used as you pad the splint, apply bandage to the splint, and then attach tapes, that is the skin traction tapes, and attach the skin traction to the end of the splint. That is how we use it as a fixed traction. This is how you, after applying the medial and lateral or the skin traction tapes, this thread will come and it will be attached to the end of the splint. So there is an indentation at the end of the splint like this, and that is for tying the knots. When you apply the knots, what is classically said is inner, under, and outer over. This is the idea is just to keep the link straight without going into excessive external rotation or internal rotation. So how can you mobilize the splint when you use the Thomas splint? This attachment is called as the Pearson's attachment, and the Pearson's attachment is attached to the Thomas splint, and you will be able to mobilize the knee by using the Pearson's attachment. Another way of mobilizing it is by using this frame. This may be present in some of the hospitals, especially in North India, and this is called as the balcony frame. And you may be taken to a bed where there is a balcony frame, and you may be asked a few things regarding this frame. So in the Thomas splint, the more important things you should know is one, historically, this is a very important thing because because Hugh Owen Thomas is considered to be the father of orthopedic surgery, and he lived in Liverpool. 11 Nelson Streets, Liverpool was where he lived. And his nephew, Robert Jones, actually he, popularized his method of treatment. And if you want to read about it, there's an article which came in JBJS 2009. You can download this and read this. Then how to take measurement, which I have already said. Then how to apply the splint, you apply the medial and lateral tapes. The medial tapes in line with the tibia and the lateral tapes in line with the fibula. And what is the difference between fixed and balanced traction? When you keep the limb in a Thomas splint and attach the tapes to the end of the splint, so the one end will be at the ischial tuberosity, the other end of the tape will be the end of the splint. This is what is called as a fixed traction. When you attach some weight to the end of the traction after elevating the foot end of the bed, the body weight acts as the counter traction, and the splint will be pulled down and it acts as the traction. So this gives some traction and counter traction. Or you can attach some weight to the end of the thread or the skin traction threads. The problem, especially when you treat these patients in the Thomas splint, it will produce excessive pressure over the ischium and can produce ulcerations. And the management of fracture shaft of femur nowadays is surgical, except in small children where it is treated in spica. All the other fractures are treated by open reduction and fixation by various methods. So it is only of historical importance. Then another thing that may be asked is, what is Tobruk splint? The importance of Tobruk splint is that it saved a lot of lives during the Second World War, because I think Tobruk is a place in Libya where the Allied forces and the Nazis fought a fierce battle in the deserts, and there the Thomas splint was used to immobilize the fracture, and they applied plaster over the fixed traction, and these patients are transported to from that area, that is northern part of Africa where the Tobruk is, to hospitals in the UK. And for transporting these patients to these places, Tobruk splint helped to immobilize the limb, and this has saved a lot of life. So Tobruk splint is important that in that aspects. If you are interested in reading war history, there are so many articles given in the net regarding the war, that is the Tobruk war. It is called as Tobruk siege, where the Australian and the Allied forces resisted the German and Italian assault for around more than 200 days, if I remember correct. So that is the importance of Tobruk splint. So this is the article which I am quoting. So its origin and its use in trauma, which came in 2009. Then regarding the fixed traction, I said you first reduce the fracture, maintain reduction. Counter traction passes up the side of the bars to the padded ring, and you application of the straps, you apply the lateral strap in line with the fibula and the medial strap in line with the tibia. So tibia is slightly anterior compared to the fibula. So the fibula strap will be slightly posterior. This will encourage slight, prevent excessive external rotation, which occurs following fracture of the shaft of femur. So this can be asked for you, what is agnus contraction? So if there is a fixed flexion deformity following, say, tuberculosis of the hip, and you want to reduce the fixed flexion deformity by giving traction, you cannot give longitudinal traction. So you obliterate the lumbar lordosis by by flexing the hip like this and keeping it in this manner. And now the limb will be like this. So here you apply the Stover splint and give traction. So gradually you will be able to correct the fixed flexion deformity. This was one of the methods that was used to correct fixed flexion deformity in the days where tuberculosis was rampant in the UK. And you should be aware who this Agnes Hunt was. She was the uh, sister who was working with Sir Robert Jones. He was working with Sir Robert Jones, and there is a hospital called Robert Jones Agnes Hunt Hospital, Oswestry, where she worked. So these things you should remember a little bit regarding the history, a little bit regarding the Thomas splint and its applications. Then now we'll go into the various methods of traction. One is the skin traction, skeletal traction. So it can be tibial traction, upper tibial or lower tibial, lower femoral traction, the trochanteric traction, and the calcaneal traction. The other methods are the pelvic traction, the skull traction, and the halter traction. So these are the various ways in which traction is used. So it can be skin traction, skeletal traction, pelvic traction, skull traction, and halter traction. Okay. Skeletal traction, these are the usual places where we use in the lower limb. Tibial traction, upper tibial is probably the commonest, followed by lower tibial traction. The lower femoral traction is still being used temporarily when you want to reduce fracture shaft of femurs during interlocking nailing. Trochanteric traction is not used nowadays, and calcaneal traction for lower or for tibial fractures or pylon fractures, it can still be used. So you'll be going into the ward, a big ward in a government hospitals. These are called as the Victorian wards, where which was these reminiscent of the wards during the time of Queen Victoria. So these wards contain a number of beds. In the hospitals in Trivandrum and Calicut, we have got wards containing around 60 to 70 beds. You will be taken to one of these beds where such a patient is given this type of traction. So, and you will be asked, name the assembly. So you have to say that it is an upper tibial traction, which is given in a Bowler board splint. So the common indication for using this is usually the fracture shaft of femur. So because in these hospitals, there are so many, and the number of patients will be, the intake will be high, and therefore you will not be able to fix these fractures on day one. So they will be given this traction and admitted to the ward, and the fixation will be done in the subsequent days. So the common indication is fracture shaft of femur, and in some cases, subtrochanteric fractures and trochanteric fractures are also given skeletal traction. Then you will be asked how many pulleys are there. You count the number of pulleys, 1, 2, 3, 1, 2, 3, and 4. So the number of pulleys are 4. Then they will ask you what are the uses of these pulleys. So the lowest pulley, this is for giving calcaneal traction and lower tibial traction. The lowest pulley is for giving calcaneal and lower tibial traction. The pulley just above is usually for giving upper tibial traction, and this is for lower femoral traction. And finally, there is a pulley here. This is the one which usually the students will not answer. This is just to prevent foot drop. You apply some tapes on the sole of the foot and attach a half kg weight here. Therefore, it will prevent the foot from going into equinus, so to prevent equinus deformity. And in those cases where there is a neurological problem like a foot drop. Then this is what I said, how will you prevent equinus? You apply the tape here, a small weight applied to the first pulley. So these are the common questions that are asked. You name the splint, you name the traction, and regarding the pulley, these things will be asked. What is the wrong here? It is applied through the wrong pulleys, because these photographs are taken when an examination was conducted in one of the hospitals where I worked. So the resident has given a traction like this, and the external examiner has taken the student to this bed and asked what is wrong here. Here, instead of this pulley, the resident has used this pulley. So another thing is what is commonly asked is what is the type of traction? You have to say that it's not a fixed traction, it is a balanced traction. Why this is a balanced traction? Because the foot end of the bed is elevated and the patient's body weight is giving counter traction. So usually it is the formula that is given is 2.5 centimeters for every lb that is pound of traction weight. Okay, and the maximum that is given is 10 kg is the maximum traction that can be given. That is 10% of the body weight. Sorry, 10% of the body weight. And in a patient weighing 60 kg, the maximum weight that can be put is 6 kg. So you can calculate how much you need to raise the foot end of the bed. That is 2.5 centimeters. So 5 centimeters for every kg. So maximum you can raise up to 30 centimeters. That is the maximum you can raise. We don't usually raise up to that level. We usually give at around 15 centimeters elevation to the foot end of the bed. So what is wrong here? So this is the knee. You can see from this is that the pulley, pin is attached at a much lower level. Okay. Then they will ask you what is the landmark. It is half an inch below and lateral to the tibial tuberosity. So the tibial tuberosity is somewhere here. It is usually put half an inch below and lateral. That is 1.25 centimeters below and lateral to the tibial tuberosity. And it is applied, the pin is applied from the lateral to the medial side. Then how will you apply the pin? That is commonly asked. You should know how to anesthetize the area by using lignocaine or a mixture of lignocaine and sensorcaine. You should infiltrate the periosteum because the periosteum is very painful. Then with longitudinal, you put a stab incision. The stab incision can be horizontal, vertical, or cruciate, which is better. The usual answer should be the cruciate incisions are much better than longitudinal and transverse. Then the pin is passed up to the level till it reaches the bone. Then which drill you will use? You will always use a hand drill, and power drill should not be used because it produces excessive heat and produce pin loosening. The name of the pin that is used, you can use either the Steinman pin or the Denham's pin. So the next question is, what is the difference between a Steinman pin and a Denham's pin? This is the Steinman pin. The Denham's pin is having thread in the middle. You can see the thread here. And the use of this thread is that it gives much more purchase to the inside the bone. So it is used mainly in osteoporotic patients. So Steinman pin and the Denham's pins are the two types of pins that are commonly used. The Steinman pin is commonly used, but Denham pin is used in cases when there is osteoporosis. Then you have to say what this is. This is the bowler's stirrup. This is called as the bowler's stirrup. What is the use of this bowler's stirrup? It fixes the Steinman pin to the skeletal traction unit. You can attach weight to the traction unit, and this is a mobile structure. This can rotate, so it can direct the traction forces in whichever way you want. So a few things regarding the history may be asked. What was the full name of Bowler? His name was Lawrence Bowler, who is an Austrian. He studied and worked in the University of Vienna. What are the contributions of Bowler to orthopedics? It is Bowler's splint. You will remember the Bowler's stirrup, the Bowler's ankle in the calcaneum, and he has written a book, one of the earliest book on fractures, that is the treatment of fractures, which was published in 1929. These were the contributions of Lawrence Bowler. So the next question is, what do you call this type when there is a BK traction and the upper tibial traction incorporated in the plaster? This is called as the Charnley's traction unit. What are the uses of this Charnley's traction unit? It prevents equinus. The pressure sore in the heel can be avoided. Rotation of the foot and the distal fragment can be avoided. Less chance of lateral popliteal nerve palsy, and ipsilateral tibial fractures can be treated conservatively. These are the 5 advantages that is given for Charlie's traction unit. That is prevention of equinus. The pressure sore at the heel is avoided. The rotation of the foot and the distal fragment can be avoided. Less chance of lateral popliteal nerve injury because the external rotation can be avoided, and ipsilateral tibial fractures can be treated conservatively. So as a resident, when you go to the ward, what are the things that you will monitor on these patients? The 5 P's, the pulse and paresthesia, the pressure source, pin tract, every day it has to be checked. Active cortisol exercises should be taught to the patient. And in those days when these fractures of the shaft of femur has to be treated in a Thomas splint, in a traction like this, you may have to take portable X-ray also repeatedly. Complications, mainly it causes distraction at the fracture site. So if there is a ligamentous injury and if you give an upper tibial traction, it will produce distraction and cause further damage to the knee ligaments. Pin tracks may get infection, that the introduction of infection can produce nerve injury either during the introduction of pin or later. And in children, you should be extremely careful because you cannot put a Steinman pin. What is usually given is a K-wire traction. There are certain K-wire tensioners are available for giving K-wire traction, but what we use nowadays is an Elizarov half ring. It is very useful in giving upper tibial traction in small children. And another complication that can occur is injury to the tibial tuberosity apophysis. The tibial tuberosity grows from an apophysis, which is usually an extension of the upper tibial epiphysis. And if it gets damaged, it will produce a genu recurvatum deformity. And it was seen in those days when fractures were treated conservatively, and especially when joint tuberculosis of the knee was immobilized for a long period in a Thomas splint, it produced arrest of the upper tibial tuberosity apophysis, and it produced a genu recurvatum, and this is what is called as the frame knee. Then you should read about this calcaneal traction, where to apply. It is usually 2 centimeters below and behind the lateral malleolus, 2 centimeters below and behind the lateral malleolus. Why you want to put it like that? You want to avoid injury to the neurovascular structures. Then regarding the lower femoral traction, it is usually the usual landmark will be line from the upper pole of the patella backwards or posteriorly, and anterior border of the head of the fibula upwards. The point where it intersect is the point where you apply this traction. The problem with this lower femoral traction is that it produces knee stiffness due to fibrosis of the extensor mechanism. So if you are taken to a bed where there is a baby, a patient immobilized in a baby splint with skeletal traction, the common questions that are asked are: name the splint and the parts. What are the uses of pulleys? Bowler's contribution to orthopedics. What is fixed traction? What type of traction is this? If you want to convert it to a balanced traction, how will you do that? You'll have to say that you will elevate the foot under the bed. The technique of introduction of Steinman pin, it is extremely important. And the complications, mainly I have mentioned the complication, and the most important is probably the pin track infection. Then how will you prevent pin track infection? That you should tell that you should you use a clean or a sterile technique. You make a cruciate incision. You will not poke the Steinman pin directly through the skin. Then you have to say that you will use a hand drill instead of a power drill. You will have to say that daily pin track care will be advised to the patients, or you will do the pin track care while the patient is in the ward. Then what is the uses of a Denham pin and what is K-wire traction? I have dealt with all these points, and these are the things that may be asked when you are taken to a bed where there is a BB splint traction. Next, we'll continue with the traction. This is a head halter traction. Head halter traction. So they will ask what this is, what splint is this. This is called as a this apparatus that is used is called as a halter traction pulley, and this is how it is being used. So this is the halter traction, and it is a simple type of cervical traction. So this is commonly used in the management of neck pain, and weight should not exceed 5 to 10 lb, and can be used for a few hours at a time. You cannot give it continuously because it produces irritation over the chin, and even sitting traction can be used for neck pain by using this head halter. So intermittent traction can be used as a OP procedure. Then skull traction, you will be taken to a bed where the patient is given a skull traction. You'll be asked to tell the indications of giving skull traction. It is usually given for cervical spine injuries. Then name the common tongs that are used. The common tongs are the Crutchfield tongs, the Gardenwell tongs, the cone tongs. So many are available. Each hospital may buy a different type of tone. Then how will you apply the skull traction? The amount of weight that is used, the precautions, and the complications. So these are the common questions that are asked when you are taken to a bed where there is skull traction. And in some hospitals where spinal surgeons are there, they may be applying this halo traction, and you should read a few things regarding halo traction also. So this is the Gardenwell tongs. Gardenwell tongs. You applied it in the intermastoid line. Intermastoid line. So this is a Crutchfield tong. Again, in the intermastoid line, you have to put it. You mark the center and put the tong and find out the places where it has to be applied. These are guarded drill bits which will penetrate only the outer cortex. You will not penetrate the inner cortex of the skull. So you will penetrate only the outer cortex, and you can see from here that it has penetrated only the outer cortex. So this is the intermastoid line where you will put this. Regarding the maximum and the minimum weight, the best way to remember is 2.5 kg for the head, and you add 1.5 kg for each vertebra. For example, for the head, it is 2.5. Suppose it is at C3-4 level. So you add 1.5, 4.5 plus 2.5. That will be at the level of 3-4. And 4-5, you add another 1.5 kg. That is the best way to remember, to a maximum of around 15 kg. Up to 18 kg or 20 kg, it can be used. So you have to study regarding the skull traction also. And halo traction, I don't have slides, but it can also be used. The common questions are that are used is one, the points where you apply these halo traction pins. And one question that is usually asked whenever you apply the frontal pins, it can cause damage to the supraorbital nerves. So how will you avoid that? And then will you apply with the eyes closed or open? You will have to always, I think, close the eyes before applying that. Otherwise, the eyes cannot be fully closed after the application because it will impinge the muscles in that area. So these are the questions that are asked. Then in pediatric wards, you will get this type of traction. This is called as the Bryan's traction or a halo or a gallows traction. So indications, fracture shaft of femur is the common indication, but there are several people who use it for reduction of DDH, especially in Japan and other countries. They use traction for reducing the DDH. So It is usually given for a child less than 18 months old. The child should not weigh more than 15 kg, and the buttocks should not touch the bed because it is the body weight that is giving this traction. This is attached to the end of the splint, and the buttocks should be raised 15 centimeters from the bed. The complication is usually when you apply a traction with the knee straight, it can reduce the blood flow to the limb, and even gangrene has been reported. And incidentally, it has been reported very rarely, but in the normal limb, not in the fractured limb. So vascular insufficiency has been reported, and when it whatever reports that has come is usually in the normal limb. So this is another method of traction, that is the modified Bryan's traction, that is used for reducing DDH. Now coming to the next, when you go into the ward, there may be one patient who is using crutches. The examiners are very interested in taking you to that bed, and they will ask you a few things regarding the crutches. What are the types of crutches, the axillary crutches, then elbow crutches, and then gutter crutches. Then how will you take the measurement for an axillary crutch? It is usually 5 centimeters below the anterior axillary fold. This is the anterior axillary fold, usually 5 centimeters below the anterior axillary fold. And the lower part, it is 15 centimeters in front and lateral to the little toe. 15 centimeters in front and lateral to the little toe, and the hand grip should be at the level of the greater trochanter. So the hand grip at the level of the greater trochanter when the elbow is flexed 30 degrees. Then you will be asked to explain the various types of crutch gait. There can be 2-point gait. What is 2-point gait? So suppose it is the right that is the affected limb. Whenever the right crutch moves forward, the left leg moves forward. So these two go together. And when the left crutch and the right leg. So this is the affected leg. So the left crutch and the right leg. This is what is called as a 2-point gait. Then there are 4-point gait, 3-point gait, swing to gait, and the swing through gait. So what is 4-point gait? It is the right leg is the affected limb. So you put the right crutch followed by the left leg, followed by the left crutch, followed by the right leg. So your injured leg comes last. So that is what is called as the 4-point. That is the injured side crutch two crutches and the injured limb. This limb and the two crutches move forward, followed by the uninjured limb. This is what is called as the 3-point gait. The next is swing through, swing to. You put both crutches forward and you swing up to the level of the crutch. Then it is called as the swing to. And if it goes in front of the crutches, you call it as the swing through. You can see this is swing to and this is swing through. So the examiner may ask you the types of crutches. You can say 2-point, 3-point, 4-point, swing to, and swing through. And some of the examiners may, if two crutches are there, maybe may ask you to demonstrate one type of crutch. Okay. Then so how can you climb up and down stairs? You always good leg up and bad leg down. You should remember this. When you are climbing upstairs, the good leg up, and when you are climbing downstairs, it is the bad leg down along with the crutches. So this is how the good leg up and the bad leg down. The crutch palsy, the improper use of crutches caused a prolonged compression of the radial nerve at the axilla, can produce radial nerve palsy, or a part of brachial plexus may be injured. So, and then a few words regarding the walking stick. The length of the walking, how will you take measurement for the walking stick? It is the hand grip should be at the level of the wrist crease. Okay, so this is the wrist crease. The hand grip should be at this level, and the elbow should be flexed 30 degrees when you take measurement. And it is 4 inches away from the lateral border, or around 10 centimeters from the lateral border of the foot. That is how you take measurement for a walking stick. This is not commonly asked. You commonly asked is usually the crutches. 4 inches from the lateral border of the foot. You remember this, the wrist crease when the elbow is flexed 30 degree and 4 inches from the lateral border of the foot. Now coming to the dressing trolleys. Okay. When you enter the ward, the examiner will ask the sister to bring the dressing trolley. In some of the old hospitals, there may be a trolley like this. And some of the newer hospitals may be having this type of dressing trays. These trolleys are not used for dressing. Nowadays, the pre-sterile dressings are available in trays. That is the one that is commonly used. But you need to know a few things regarding these dressing trolleys. So the top shelf, which are the things, usually the sterile things are kept in the top shelf, like the sterile dressings. Then there will be a kidney tray, the hand towel, sterile gloves, and acetyl forceps. In the lower, it is usually the drum containing the bandages and gamchi, antiseptic solutions, the kidney trays for dirty instruments. All these are kept in the bottom shelf. So usually they may ask you what are the things that should be kept in the top shelf and what should be kept in the bottom shelf. So the next, there may be a bin like this. So immediately the examiner will ask you how will it, what is inside. Usually it will be the gamgee pads and other dressing materials inside. And the next, they will go into the methods of sterilization. How will you sterile this? Then you will say that it is the steam that sterilizes it. You sterilize by autoclaving. The autoclaving usually produces steam, and it is the steam that is entering. And then the examiner will ask you, there are no holes inside here. How can the steam enter into this bin? Well, your answer should be there is a lock here, and you can open the lock. Once you unlock it, you can see the holes here. When it is fully autoclaved, you lock it, and after that, you should not open that. But because if you keep it open, then the inside becomes unsterile. Then you have to read a few things regarding sterilization. I have not included in this talk. Another favorite question is regarding this Cheetle's forceps. This Cheetle forceps, how will you keep this Cheetle's forceps? It should be kept in an alcoholic solution or Savlon. And how often will you change the Savlon? Savlon should be changed daily, and the Cheetle's forceps should also be autoclaved daily, because there are several studies which show that if you keep it in Savlon for a few days, the Pseudomonas will go in the Savlon. The bacteriological evaluation of this is one paper, which according to that, we strongly recommend that Cheetle's forceps should be kept in a bottle containing glutaraldehyde or chloroxynolone. So that's taken from a article which came, which I happened to see in the net. Then now gamgee pads are available. So immediately the examiner will ask you who described this gamgee pad, why this, how this name came. It was Dr. Joseph Sampson Gamgee in 1880 who described this gamgee pads. It contains a thick layer of absorbent cotton wool between two layers of absorbent gauze. So that is a Gamgee pad. Then regarding the materials used for dressing, regarding the spirit, so you all know during the COVID times that it is the 70% alcohol that should be used because that below that level 70% it doesn't have any sterilizing property. It acts by dissolving cell membranes, protein denaturation, and dehydration of the cells due to evaporation. That is the mechanism. Protein denaturation, dehydration of the cells due to evaporation, and it dissolves the membranes, the cell membranes. It is bacteriostatic, antiseptic, mild rubrication, counter-irritant when used to an excoriated skin. It is a broad spectrum antimicrobial activity against vegetative bacteria, including mycobacteria, viruses, fungi, and but it cannot destroy the spores. That is a disadvantage. So it is virucidal, fungicidal, bactericidal, but it is not sporicidal. Another is Savlon. What is the full name of Savlon? It is chlorhexidine gluconate with cetrimide 16% and isopropyl alcohol. It is yellow because of the presence of tartrazine. It is germicide and detergent. So what is the concentration that is used? 1 in 30 aqueous solution. Uses, it is for cleaning and disinfection of physically dirty wounds where extra detergents are required. Then another material that is used nowadays frequently, especially when you sterilize the arthroscope and all, is Sidex. The Sidex is activated glutaraldehyde solution 2 to 4%. It is a broad spectrum. It has got broad spectrum activity against bacteria and their spores. It is sporicidal, fungi, and viruses. So it is noxious and irritating to the tissues, and hence thorough rinsing of all the exposed materials is mandatory. And pseudomembranous laryngitis has been linked to disinfection of tracheal tubes with glutaraldehyde. Since it is an irritant, you need to wash the instruments with sterile saline before using these instruments because it is noxious and irritating to the tissues. Another favorite thing is the U-Sol. What is U-Sol? It is Edinburgh University solution. U-Sol is Edinburgh University solution. What does it contain? 12.5 to 1.25 gram of boric acid and 1.25 gram of bleaching powder, that is chlorinated lime, in sterile water up to 100%. U-Sol should be prepared and used fresh every day. That is very important because you cannot keep it for many days. So your pharmacy should be able to prepare U-Sol solution. What is the mechanism of action of U-Sol? It releases nascent chlorine. What are the uses? It separates slough. So when there is a lot of slough, you can use U-Sol, like blood sores, infected wounds, and ulcers and burns. And acidic in pH and thus useful for dressing of the wounds infected with Pseudomonas. These are the two main indications, mainly for as a de-sloughing agent it is used for infected wounds contaminated with Pseudomonas. Hydrogen peroxide, it is 20 volumes of hydrogen peroxide releases 20 volumes of nascent oxygen. The effect, its action is by nascent oxygen. In the case of U-Sol, it is by nascent chlorine. Here it is by nascent oxygen. It is effective bactericidal, fungicidal, virucidal, and sporicidal. And 0.5% of accelerated hydrogen peroxide demonstrated bactericidal and virucidal activity in 1 minute and mycobactericidal activity and fungicidal activity for 5 minutes. So what are the important functions? It destroys the anaerobic organism. That is the most important thing. When you suspect anaerobic organisms, because it releases a lot of nascent oxygen, hydrogen peroxide is extremely useful in these situations. Second, it produces a lot of frothing and thus brings out debris from the depth of the wound. And third, it produces heat on the tissue contact and thus prevents capillary using. Hence, it is used as an hemostatic agent. In the previous days, for preparing acetabulum and the medullary cavity, hydrogen peroxide was used. Nowadays, it is not commonly, it is not used nowadays. So the fourth is it is used for removing blood stains from the clothing. These are the main functions of hydrogen peroxide, and it acts by releasing nascent oxygen. Then betadine is another solution which we all use daily. What's the concentration? It is 5% and 10%, but in the scrub it is 7.5%. It has got germicidal. It has got effect against bacteria, virus, fungi, protozoa, and yeast. So then immediately iodine is much cheaper. Why are you not using iodine? Because iodine has been used for years or even centuries for the same purpose. Why you are not using iodine nowadays? Because of three properties. One, insolubility, instability, and irritant and staining properties. Iodine is insoluble, it is unstable, and it is irritant, and it causes staining. These are the properties or the disadvantages of iodine. So these three or four undesirable properties of iodine is not there in the case of betadine. This can be eliminated by adding polyvinyl pyrrolidone or povidone. It's an organic polymer which is water soluble. So combination lead to a complex formation polyvinyl pyrrolidone iodine or povidone iodine containing bactericidal activity of iodine without the other three effects: insolubility, instability, and irritant properties and staining properties. Now coming to plaster of Paris. So you'll be shown taken to a place where the patient is having a slab and then or a cast in the ward, and you'll be asked a few things regarding plaster of Paris. One question that is commonly asked by senior examiners is why it's called plaster of Paris and why it is not called as plaster of some other place, because why Paris is so important. This is because the gypsum is extensively mined in a place called Montmartre in Paris district. So first it was discovered in that area, and that is why it is called as the plaster of Paris. And there is a story behind that which is available in the net, and you can read that. Who described the bandages for fracture treatment? It was Antonius Metitsen and Nikolai Ivanovich Pirogov. So these are the persons. You at least remember the first name, Antonius Matithsen is the person who described it first. What is the chemical formula? It is calcium sulfate hemihydrate. So plaster of Paris is prepared by heating gypsum at 120 degrees. So it is not the gypsum. It is not the gypsum as such that is the plaster of Paris. It is gypsum. It is heated to 120 degrees. And if you read the history, you can find out how the fire occurred in that area in Paris, which led to the discovery of plaster of Paris. So this is the formula of plaster of Paris. Then they may ask regarding the plaster of Paris slabs. So how many layers of plaster will you use? 8-layer slab for the upper limb, 12-layer slabs for the lower limb, 8-layer for the upper limb, and 12-layer for the upper limb. Then regarding each of these, you should know the extent. Long arm cast, the extent. It extends, proximal extent is just below the deltoid insertion, and the distal is up to the knuckle. And on the volar side, it should not extend beyond the volar trace, because if you extend it below that level, it will produce limitation of metacarpophalangeal joints, which becomes stiff. Then so many questions can be asked, why it becomes stiff, and what is Gibbs-Jones position, what is functional position. These are the questions that are commonly asked, which you should go and read. The cylinder cast, this is the cylinder cast which is usually given for immobilizing the knee, fractures of the patella and knee injuries. And The main disadvantage is that it produces a lot of pressure over the Achilles tendon. So Achilles tendon is subcutaneous, and if a sore occur in that area or an ulcer occur in that area, and it is very, very difficult to treat. That is the main disadvantage of leg cylinder cast. Then there may be a patient. Usually there will be one patient with a BK cast or an AK cast, and the extent will be asked. It should be 2 centimeters below the tibial tuberosity and distal up to the metatarsophalangeal joint. What problem is seen in this cast? So the angle is in plantar flexion and in varus. So what is the disadvantage of keeping the foot in equinus for a long time? You should tell the reason for that. That is mainly because of the peculiar anatomy of the talus. The talus is wider anterior compared to posterior, and therefore in equinus position, it is the posterior part of the talus that is engaging inside the ankle mortise. Therefore, the ankle mortise becomes smaller, and if you keep it for 6 to 8 weeks, then you will not be able to dorsiflex the foot. So it leads to a fixed equinus position. Okay. So which are the situations in which you purposefully put in equinus position? There are two conditions. One is conservative treatment of fractured neck of the talus, and second is tender Achilles injury. Okay. Then regarding long leg cast, again the extent will be asked from the lower two-third. The upper one-third will not be covered. Lower two-third will be covered, as different from a groin to toe cast, which extends from the groin up to the metatarsophalangeal joint. This is the lower two-third of the thigh up to the metatarsophalangeal joint. Then another question that is commonly asked is why do you want to keep the knee in flexed position? It is commonly used in fracture tibia and fibula, and this flexion is to prevent the rotational movement of the body being transmitted onto the leg. The rotational movement of the body is prevented from being transmitted to the leg by keeping it in the flexed position. And second thing is, in the flexed position, it also relaxes the gastrocnemius muscle. The spica, the extent of spica can be asked. The indications, fracture of the hip and femur in children, and DDH, extent of the spica from the nipple line to the toes. What is a single spica, double spica, and 1.5 spica? This is a double spica. If it extends up to here and this leg part is paired, it is a 1.5 spica. And if only this leg is immobilized, you call it a single spica. What are the problems in a spica? One important problem is the cast syndrome. What is cast syndrome? It is the obstruction of the third portion of duodenum by superior mesenteric artery, leading to a high intestinal obstruction. So it is the superior mesenteric artery that get compressed, and this leads to an intestinal obstruction. So whenever you are putting a spica or a spinal jacket, especially after correction of scoliosis, you need to examine the abdomen. How will you examine the abdomen? There is in the spica, you make a hole anteriorly. This is what is called as the dinner pad. So if it is there, the examiner will ask you what is the purpose of it. What is the name of that dinner pad? So what is the purpose of the dinner pad? It is not for taking a sumptuous dinner, but it is for palpating the abdomen, because you are discharging the patient and the patient will be miles away. And in the night, if the patient complains of abdominal pain, and surgeon in the local area needs to examine the abdomen. So you need to give an adequate space in the spica for examination of the abdomen. Cast syndrome, when does it occur? Following immobilization in spica, body cast after spinal surgery. Symptoms are usually abdominal pain, distension, and vomiting following the application of spica. So the best thing is you admit the patient for at least 24 hours after putting a spica or a spinal jacket or a body cast. nowadays, Ponseti technique has become very popular, and there may be at least one patient in the ward with this Ponseti cause. And you should know everything regarding this Ponseti cause, indications, the steps in the correction, that is cave, cavus, adductus, uh, varus, the heel, and equinus by tenotomy. How is heel varus corrected? The heel varus, when the forefoot goes into abduction, the heel varus get automatically corrected. And what is reverse Ponseti or the Dobbs method of casting, that is used for congenital vertical callus. So I'll not go any further regarding that, but you have to know everything regarding the Ponseti cast, the Ponseti brace. All these can be kept at either in your ward rounds or in your viva. Rotation stop is not usually used nowadays. It is used in the conservative treatment of, was used in the conservative treatment of trochanteric fractures. It is only of historical importance, and it produces a lot of complications. The scaphoid cast may be asked. There may be a patient with fracture scaphoid in the scaphoid cast. The position of the wrist is usually in the glass holding position, that is dorsiflexion of the wrist and radial deviation. The extent below the elbow crease to the knuckle dorsally and distal volar crease up to here only, and up to the PIP joint of the thumb. This extent you should remember. There are several ways of putting scaphoid cast. If you read the books, some people will give the cast up to the tip here, and there are some reports which say that you need to immobilize the index finger also, but these are only used in rare occasions and not popular. But this is the scaphoid cast that is used commonly. Then there may be a patient with this type of plaster. This is called as the patellar tendon bearing cast, or the PTB cast. It was described by Augusto Sarmiento, and there's a good book, that is the Functional Bracing of Fractures by Augusto Sarmiento, and it is mainly used in the treatment of fractured bones of the leg. So molding over the tibial flare is very important, and you can mold over the patellar tendon bearing firm cast, and the whole soft tissues will act as a hydraulic column, and it starts transmitting weight. So instead of going through the bone, the weight will be transmitted by the hydraulic column to the tibial, upper tibial flare, and to the patella. So as the bone starts uniting, the body knows how much weight can go through the bones, and therefore gradually more and more weight will be starts to be transmitted through the bone. That is the theory of patellar tendon bearing, or the cast bracing. Now, these type of modern plasters also are frequently used, and this is a fiberglass casting tape, and it is lightweight, strong, porous, and durable. But the disadvantage, it is very difficult to cut it. Then you should know regarding this polyester cast also, because now it again has become popular. It has got better conformability, so it is easy to apply, and you can use a regular scissors for cutting it, and it works for circular, rigid, semi-rigid casts, splints, and orthosis. And three-way stress open knit polyester conforms to the body contours. And the main advantage is it is 100% radiolucent, and it is washable. These are the two things. Along with that, you have got the Delta Cast Dry, which is the padding material that is used along with these Delta Cast plasters, Delta Cast Soft. So that regarding the plasters and the uses of plasters which will be there in the ward. Occasionally there is a patient in the ward. This is not, this is a locally used vacuum assisted closure. You should know regarding that. You have got the vac machines in the big hospitals. People are using these because it is expensive. In most of the local hospitals, you are using the same principle, by using Romovac suction or by giving intermittent suction from your suction apparatus. I have used in government hospitals these methods, and it is equally effective as what is being used in other the costly apparatus that is used in other hospitals. Because I used to work in government hospital, and now I am working in private hospitals, and therefore the effect is almost the same. So there is no harm in using this type of treatment, even if you are working in a taluk hospital or a district hospital. How does it act? These are the advantages. It reduces the edema. It increases the blood flow. It reduces bacterial colonization. It increases granulation tissue formation and increase protein synthesis and cellular proliferation. So these things you should read. At least you should say that it reduces edema, increases blood flow, and reduces bacterial colonization. In effect, it increases the granulation tissue formation. So what is the ideal pressure that may be asked? It is minus 125, minus 80 to 125 actually. The advantages are early healing of the wound and reduces infection. And the main disadvantage is that it cannot be used in an open, in a bleeding wound because it produces hemorrhage. Then in the meantime, they may ask you what is antibiotic bead pouch technique. So it is given in the AO book. So antibiotic cement beads fill the dead space, which is high in antibiotic concentration. You seal it further. We usually use opsite for sealing that. So the infection rate decreased by using this antibiotic bead pouch technique. So that is advantage and disadvantages. Okay. And on entry into the ward, you may find these bins there, and you should know biological waste management is extremely important nowadays, and you should have a general idea regarding this biological waste management. I will not go into the details. You should study what is there in the yellow bin, red bin, the black, and the green bin. Okay, and these are the things that are usually kept, and you should read that. Then finally, a patient with the suction drain may be there, and then they will ask you regarding closed suction drain. How long will you keep it? Usually for 24 to 48 hours. What are the advantages? Eliminate dead space, prevent accumulation of fluid and blood, evacuate existing collection, and reduces the infection rate. So these are the advantages. So is there any condition where it is not being used? So usually if such a question is asked, you can say that it is not wise to use it when you are using antibiotic beads, because the antibiotic beads elutes antibiotic, and if you put a suction there, it will be sucked out by the drain. Then catheter will be there. Sorry. Suction catheters may be there. So Foley's catheter with Euro back. Then what size of the catheter will you use in males and females? 14 for females and 16 for males. So usually you will say that 14F. Then immediately the examiner will ask you, what is this F standing for? The answer should be the French scale or the French gauge. It is 1/3 of the diameter. That is, French is diameter in millimeters into 3. Okay, or French divided by 3 is the diameter. So the diameter is 1/3 of F. Suppose it is 12F means 12 divided by 3. 4 will be the diameter of that catheter. The types of catheters you should know: the external catheters, that is the condom catheter, the indwelling catheters, the Foley's catheter, and the self-intermittent catheterization you should know. These are the common questions which you should read and learn how to introduce the catheter, then how to inflate the balloon. Regarding inflating in the balloon, how much fluid will you use? Usually in here it will be written how much fluid has to be used. It is not 5 ml, 10 ml or 15 ml. What is given in that particular catheter will be the amount of fluid that should be used. how to remove the catheter. Then if the catheter is not coming, what will you do? You will have to say that you will cut this, cut here, and if it's still not coming, yeah, you will have to use a suprapubic puncture. What are the other urinary catheters? The silicone catheter, the PVC catheter, that is the K90 catheter, that is commonly used for intermittent, self-intermittent catheterization. It is another thing which you should learn because it is commonly used in paraplegics, and the Malicote's catheter. These are the other catheters that is used, and you should read about self-intermittent catheterization.
You can, yes, sir.
Yeah. Should I continue, or there are?
Yes, sir. No, sir. Continue, sir. No issue, sir.
So what is shown in this picture, it is the pressure sore, because there may be one or two patients with pressure sores, especially paraplegics. Then you will be asked a few questions regarding pressure sores. Pressure sore is produced by a prolonged pressure leading to ischemia of skin and necrosis. And what is the mechanisms? The mechanisms are compression, shear, friction. These are the three mechanisms. Okay. So classification of pressure sores, you should know. I will not go into that. What is grade 1, what is grade 2, what is grade 3, and what is grade 4. Then the treatment of pressure sores prevention, avoid prolonged pressure, avoid friction and shear by proper beds, that is the air bed. Then skin care and nutrition and hydration, treatment of medical conditions. Then treatment, cleaning and dressing, debridement, the vac dressing, and providing adequate skin cover. You should know how to cover these flaps. For example, in a sacral bed sore, you can use the gluteus maximus flaps. If it is in the ischial area, you can use the tensor fasciolata based flap. External fixators, I think, has already been taken, I think.
Not yet, sir, but we will ask Jagdish, sir, for this. Last time we have asked him.
So I will skip this.
Sir, we have time, sir. Time is not an issue today.
Okay. Then I'll just charge my.
Right, sir.
I'll charge. So external fixators can be asked. Okay. So what are the components of these are the common questions that are asked. One is the components of the external fixator, the pins that are used, how to apply the shank screw, the shank pins, how to apply the fixator for the shaft of the tibia. When there is a mid shaft of the tibia, the procedure of applying an external fixator to the shaft of the tibia. Then how will you increase the stability of the fixator? The complications, how will you prevent the complications and treat the complication? How will you dynamize the fixator? And regarding modular fixators. So the name of this part of the assembly, this is a universal clamp. Okay, you have to say that this is a AO universal clamp. So this is a T clamp. This is a rod-to-rod clamp. This is a shank spin. Then the tip of the shank spin is usually trocar shaped, but there are other varieties of shank spins are also available. You get conical shank spins, which are mainly used for LR assemblies and orthofix. So this is a very, very important instrument that you should all start using whenever you apply the external fixators. The name of the instrument is a triple trocar. Okay. So this is used for introducing the pin. This sharp area, first you tap onto the bone, then remove the inner one, then through this one you drill, and then remove that, and through the outer one you put the shank pin. So this reduces the injury to the soft tissues. If you just start, especially in the femur, if you start drilling, all the soft tissues will be turning around your drill bit, and it produces a lot of soft tissue damage, and the wound get infected within a couple of days. So don't you put an external fixator, especially in the femur, without a triple trocar. Then these are monoaxial fixators. Then the question will be, how will you increase the stability of the fixator? One method to increase to add the number of rods. So here, if you say the pins, one pin should be near the fracture site, and the second pin should be away from the fracture site. So that is the principle. And this rod should be as close to the bone as possible, but it should allow proper dressing of the wound. Third, you add one more rod. And four, this is a joint spanning external fixator. Okay. The another method is to make it into a delta frame. You add one more rod in a different plane. That is what is called as a delta frame. Or you make it into a triangular assembly like this. Especially in pylon fractures or fractures in the lower end of tibia, you can use a triangular frame. The complications, mainly it is the pin track infection. Pin track infection, they may ask regarding the classification. This is one classification that is commonly used. Grade 1 is inflamed. Grade 2 is serous discharge. Grade 3 is purulent discharge. Grade 4 is osteoarthritis. And grade 5 is ring sequestrum. So in grade 1, daily pin care is all that is necessary. Grade 2, pin care plus antibiotics. Grade 3, antibiotics and pin care. The indication for removal is usually the loosening of the pin, that is following osteolysis and the presence of ring sequestrum. The components of the external fixator, I have already said this. How to apply the shank pins? It's almost the same as what I have said in the introduction of Steinman pins. Okay, so I will not repeat that. Then how to apply the fixator through the shaft of the tibia? You can read the what is given in the AO book. They advise us the far pins first, followed by the near pins. Okay, so if there is a fracture in the mid shaft of tibia, the far pins first, then the near pins. How will you increase the stability? I have already said, you make it close to the skin. Second, you add one more rod in a uniplanar assembly. You make it into a delta frame and an interconnecting rod over the fracture site, an oblique interconnecting rod spanning the fracture site. So this increases the assembly of the rigidity of the assembly. What are the complications? Mainly it is pin track infection, and during introduction it may damage the neurovascular structures. But the most important, as far as orthopedic surgeons are concerned, the frame is too rigid and it can produce delay in the union. That is why it is not being used as a throughout the treatment of these fractures. It is used as a temporary measure in the management of compound fractures. But if you want to use it as a measure during fracture treatment, you need to dynamize the fixator. Immediately, they will ask you, how will you dynamize the fixator? So the method is, okay, I'll go back and show you. So, suppose you want to dynamize this fixator and make the patient walk on the fixator. You loosen the diagonally opposite clamps. So these clamps and diagonally opposite clamps, one from the lower rod and the other from the upper rod, are loosened. Therefore, it gives some amount of axial compression, but it will not give any rotationally instability. That is how you dynamize this rods. Then regarding modular fixators, suppose you want to fix the tibia, you can make it into 2 frames with small rods, one for the proximal fragment, one for the distal fragment. You fix the proximal fragment with 2 pins and 1 small rod. You immobilize or stabilize the distal fragment with 2 pins and 1 small rod. Then you, under C-arm, you reduce it by manipulating the fracture site. And if, once the reduction is stable, you put another rod connecting these 2 rods by using rod-to-rod clamps. That type of fixator is what is called as a modular type of external fixator. Then these just fixators are used in the wrist, and this may be there in the ward immediately. What are the indications, or how will you put the pins to the radius? The important thing regarding the wrist, the pin that is introduced into the radius is you have got the superficial branch of the radial nerve in that area. So you need to expose the bone before putting the shank pin. Otherwise, it can cause damage to the superficial branch of the radial nerve. How will you put the pins to the metacarpals? Usually there is a superficial area in between the extensor tendon and the interosseous muscles. So you can palpate the dorsolateral area. You can feel the second metatarsal underneath your skin. In that area, you put the shank pins. The complications, usually it is the injury to the superficial branch of the radial nerve. Second thing is, if you impale the muscles in the in that area, in the index finger metacarpals, it will produce limitation of movement of the index finger. So Elisaro, I think it will be dealt later by in the talk on external fixators. But these things you should know. You should identify the various components of the Elisaro fixator. This is a half ring. This is the Elisaro K-wires. This is the spanner. This is what is called as a rancho cube. The male post, the female post, the hinges, then the various types of bolts. This is an ordinary bolt. This you can see a hole in the center. This is central hole bolt. Here you can see there's a slot at the side. This is called at the side slot bolt. Then this is a nylon nut. There's a side plate. Here you can see a slot here. These are washers. Here is a slotted washer. And this is an ordinary washer. This is a slotted washer. This is a twisted rod. So it is again the same, the ordinary bolt, the side slot, and the center hold. Nylon nuts. Then these are the posts, so male and female. The pins. This is an Italian arch. This is the oblique support. So these things you should know. Then what is an Elisaro fixator? You should know. You will be asked to name the components. The diameter of the wire that is used is usually 1.6 and 1.8 mm wires. The tension that is used is usually between 90 and 130, depending on the age and the weight of the patient. Then olive wires and drop wires. What's the difference between olive wires and drop wires? Then the ideal pin crossing angle, it depends on the anatomy of the area where you are putting these wires. What are the safe zones? And what are hybrid fixators, where you can use 2 types of external fixators. In the upper part, you use Elisaro, and here you can use the AO type of fixators. And nowadays, in several hospitals, they are using these SUVs and spatial frames, and you should have an idea regarding these SUVs and spatial frames. I think it will be dealt later. I think Jayant is an expert on all these, and he will be talking about this. Then this is the LRS assembly. The important thing regarding this is the type of pin that is used. That is the conical shank pin. What is the advantage of conical shank pin? It gives radial preloading. What is the disadvantage? If you introduce, you should use a C-arm when you introduce this conical shank pin. Because if you Introduce it too far, you cannot withdraw it. The pin becomes very loose. The advantage, it gives radial preloading. Disadvantage is pin cannot be withdrawn if it has penetrated too far. So you should know a few things regarding this LRS. Nowadays, this type of orthofix type fixators are used in the management of, this is one case where there is a varus deformity of the tibia, medial compartment osteoarthritis. You want to do a high tibial osteotomy. Through a small incision like this, you will be able to correct this varus deformity by using this orthofix fixator. It is a very useful thing. So this is a orthofix fixator. And in those cases where we are using this type of fixators for the correction of clubfoot, this type of patients will be asked, will be there in the ward. They may ask you what it is. It is the Joshi's external stabilization system, which was described by Professor Bridge Fusion Joshi, used in clubfoot, and you can use it for Joshi's finger methods of correction of finger injuries, the wrist distraction. What is the principle in a clubfoot? It is the differential distraction. So you distract more on the medial side and less on the lateral side. Why do you want to distract on the lateral side? Because you want to prevent compression on the lateral side. If you just distract here, the bones get compressed on the lateral side. That is why you are using differential distraction. Nowadays, instead of just, we are using UMEX, that is universal mini external fixated system, which has got knurled rods. Now coming to chest tube, there may be patients with chest tube in the ward. So you may be asked regarding a few questions regarding this. What are the indications? Chest injuries following thoracotomy, flail chest, and Stowin test. They may ask, what is Stowin test? It is the collapse of a segment onto the chest wall. And the flail chest means the segment of the rib cage breaks. So there are double fracture of the rib. So there is a free segment. It gets detached from the rest of the chest wall. Therefore, it produces what is called as the paradoxical breathing. Usually when you inspire, the chest expands. So here, the paradox will happen. When you inspire, that part will be drawn in, or the flail part will be drawn in. When you expire, it will move out. That is the paradoxical breathing. And how will you introduce the chest tube? Fourth intercostal space in the anterior axillary line. What are the precautions for transporting the patient? You should always clamp the chest tube before transporting, because fluid will be there and it will go into the chest. When to remove the chest tube? Usually when the daily drain is less than 50 ml. So these are a few things which I have collected. Okay.
Thank you, sir.
So sorry. So I'll stop share now.
Yes, sir. Thank you, sir. Kakatkar, sir.
I think it was a very exhaustive discussion of practically every point that one can see in the wards, and I think Gopa Kumar sir has covered almost all the aspects. A lot of theoretical questions also he has already answered, and given a lot of ready-made material for the students to get through this particular head with very good score.
Thank you, sir. I think Jain sir's book and Gopa Kumar sir's today's class, student should score, if not less, but at least 99% of that 40 marks. So I think Jain sir is.
That's too much of.
30 out of 40.
Yes, sir. So thank you very much, sir. I think we can skip today's question answer session, and students are requested to read whatever basic things they have, and they can put their questions on our chat box or WhatsApp group. Then from there we will either answer or I will direct them with address of answer so that they will read few more things. Today, being master of masters class again, there will not be any comments from any senior faculties. Anything faculties want to ask and clarify for themselves, that will be good. So I will request the faculties to share if they want to add something for exam related things. And with this, we will conclude our session. So I'll start with Mohanty sir.
Gopal, you should be able to tell something regarding this Tobruk war, siege of Tobruk, because
Right, sir.
you're from the
Def-
army.
Right, sir. Right, sir.
I
I
have
will get the
the
details.
and other things.
Yes, sir. I will get the details, sir, and I will do that, sir. That will
Okay.
be my homework, sir.
Okay.
Mohanty sir.
The excellent lecture, enjoyed thoroughly. I just wanted to ask, sometimes in exams asked regarding Thomas splint, that which side limb you will measure, the injured side or uninjured side? Which side, sir, should we answer?
This is the uninjured side. Uninjured and add two inches.
Okay. Sometimes, sir, I don't know. Some books have written that injured side because there are a lot of swelling sometimes is there in that injured side. So better that you measure the injured side and add 2 inches for the future swelling to occur.
Usually what is given is the injured thing. And again, the correct method is not to use bandage. They ask for calico clothes, which are used in Western hospitals, where they have got this calico cloth. And at least 2/3 of your leg will be below the level of the splint. Only 1/3 should be above. So it will be sagging. What we have seen is the attender will put a tight bandage there and will put the limb on that. That will produce a lot of discomfort. Actually, you need calico clothes and big pins for putting that.
Yeah, that's the classical method of preparing a Thomas splint. That cloth is actually applied in a sort of sagging form so that it accommodates the bulk of the thigh muscle. And I have seen, the tight bandages which are applied on the splint causing sores onto the thigh because of the tight pressure. Not only the ring sores in the ischial tuberosity, but even on the backside of the thigh, I have seen patients developing the sores because of the tight bandage. Even on the tendo Achilles, I have seen patients landing up with sores. So, like in the upper part of the thigh, ideally you should have a sagging bandage even just at the level of ankle also. And you should protect that tendo Achilles in the Thomas. Otherwise, you can land up with a sore in that area.
Actually, one of the method to avoid the narrowing of the diameter, take the bandage in longitudinal, so that it is not, horizontally tight. If you take bandage in a longitudinal way, they are at the level of the ring.
Sir, ideally they say that minimum 3 level cloths should be used while making the Thomas splint. Not too many things, only at 3 places. So I will request Gopa Kumar sir and Kakatkar sir to put some to throw some light on these 3 points of applying this cloth. Kakatkar sir.
Yeah, one is below the thigh, the second one is below the knee, and the third is below the calf muscle, where you should have a sagging of the muscles allowed in the 2 areas of the muscle bulk, and comparatively a more stiff or tight cloth underneath the knee, where the knee shouldn't sag behind. And they used to recommend use of safety pins to fix the cloth which is there.
Sir. Gopa Kumar sir.
Yeah, it's the same. You should allow the limb to sag down.
Yes.
It should not be too tight because the diameter of the thigh varies. So in the upper part it is big, and in the lower part it becomes thinner, and the calf is also bulky. Below that it is thinner. So
Sir, in exam.
I think your MSF have given some details regarding this, if I remember correct.
Sir, I will give
Some guidelines also, because regarding traction I have seen, because I have read that.
right, sir.
Another point on Thomas's splint. You know, sometimes if the lateral strap goes too high and it reaches up to the fibular head, the traction can cause a lateral popliteal palsy. So one should be very careful while putting the lateral strap that it shouldn't reach up to the head of the fibula. So that is also one of the precautions. Some people are fond of asking, you know, if the strap goes higher up, what will happen? And the patient can have a traction palsy of the lateral popliteal because of the high
Sir, regarding BB frame, Bowler's Brown frame, when to say in an exam that it is a frame and when to say that it is a splint when photograph is shown. Same applies to Thomas splint also. Whether this is a Thomas apparatus or frame or Thomas splint. BB frame, BB splint, Thomas splint, and Thomas this ring. There's some clarification.
These words are used synonymously. It is what is given is usually BB splint and Thomas splint. I don't know why it is called as a frame.
Sir,
people using it as frame.
Sir, when it is made ready to use, means by applying some cloth or some gauze bandages, then only I think we should say it as a splint. Otherwise, it's a frame and which is of no use for our use.
Yeah, these are all theoretical.
I think it's a hair splitting.
These are whims of few examiners.
Exactly.
But the only thing is Thomas splint still has got some application, because I have seen in the casualty that when a fracture shaft of femur comes, even with double fractures, they are sent for X-rays and CTs without proper splinting of the fracture. It is practiced in several hospitals.
I think, sir, Thomas splint is very much relevant. I will request Kakatkar sir to tell us about the fixed traction and effective use of, I can say, Thomas splint, sir.
Well, I think Gopa Kumar sir has already made it very clear that when you tie both the traction is fixed on both the sides of the Thomas splint. That one side it touches the ischial tuberosity, and on the other side you have tied it toward the lower end of the Thomas splint. Then it is called as a fixed traction. And if you put it on a pulley with the frame and this Thomas splint lifted up, then it is either you can call it as a sliding traction, wherein there is a continuous traction exerted because there is a weight applied on a pulley at the end of the bed, rather than fixing it onto the Thomas splint.
Thank you, sir. Samantha, sir.
That
Yes,
sliding traction
I want to
is
ask
also called as a buck's traction. You know, some people are
Yes,
fond
sir.
of asking,
Yeah.
what is that
forgot
sliding
that
traction
bucks.
called as?
Sir,
So that is called as a buck's traction.
sir.
Yes,
Sir,
sir.
I have two questions, sir. One is regarding, sir. One is regarding hanging cast, sir. Sir, there is some confusion in our understanding, Gopa Kumar, sir. In humerus fractures,
was used in shaft of humerus fracture. The only thing is it should extend above the level of the fracture. That was what was applied. Below the level, it produced angulation at the fracture site. But now it is not being used because the disadvantage is distraction.
sir. But distal extent of this hanging cast ideally, sir.
Usually, it is described as it is something like a long arm cast. But even if you extend above the wrist, the problem is edema of the hand. So it's better to apply it as a long arm cast, extending above the fracture site.
Jain, sir, you want to ask?
Yeah, I wanted to ask one question to Samantha, sir. I had been to Peerless Hospital, his institute, and my co-examiner, his colleague from the department, was asking students about crash cart. I am also not very much aware of what are the different sections of crash cart. If you can explain it to us.
I couldn't understand what your voice is cracking.
Crash cart. There was a crash cart kept in the ward.
Oh, crash cart. Okay, now I can understand.
We don't
Okay,
know. We
crash
don't
cart.
know a lot of things about crash cart.
No, no,
Your
crash cart
colleague
means
from the hospital was asking every student about it. I
no,
was
no, no.
keeping silent.
No, no, no. Crash card is not been asked. Most of the time, it is not been asked in the practical exam. It is basically some life-saving drugs where you keep in the ward. It is not in the dressing trolley. Basically, it is in the custody of the sister in charge who is in the ward. Okay, suppose you like your adrenaline, your deriphyllin, your lycotine, all these basic life-saving drugs. What you keep in the cart, that is known as the crash cart. It is not been kept in the either in the dressing trolley. It is marked with the crash cart just for the life-saving purpose.
Jain sir, I can tell you because we are having 20-bed ICU.
Okay,
That
sir.
what Samantha sir has told, all these life-saving medicines, including intubation tubes and other things, they are kept in a cart, a trolley, which has got all these sections, and in that everything is there. That is what we call is crash cart.
Sir, the question was asked, कौन सा shelf में adrenaline रहेगा, कौन सा में
अरे
tube
बाप रे,
रहेगा. तो वो मुझको खुद
orthopedic
को
का
नहीं आया.
तो
Myself was not knowing anything about it.
No, it is not been regularly been asked. You and me have taken most of the exam. It is not been asked most of the time. But people, those who are listening to the meeting, today's class, they must be noting. If you are asked for the cash card, that means it is the medicines, the intubation tube, and all this, which is practically when you have to save the life of the patient at the ward itself, so that you are basically you are not searching for the all the life-saving medicines. So that is the crash card. It is actually kept to the sister in charge of that ward.
Actually, sir, when we work in MSF in war scenario, emergency scenario, there is one trolley in emergency area, sort of the side table locker we have in wards. Similar sort of drug equipped, all the contents in available there. They are enlisted there, and which drawer contains which drug is already enlisted there. So even if some new person comes and he he throws some, means he gives at least 1 to 2 minutes just to snare at that whatever is stuck there, it becomes very much clear, sir. I think this must be similar to what this crash card you
Yes,
all are
yes.
telling, sir.
Basically, whatever is like your, if you go to the bridge, basically you are asking your anesthetists, they are also having the crash card ready in every OT. In what
Life-saving drugs, sir. Yeah.
life-saving,
Life-saving drugs.
all the it is in a separate drawer in the boils basin. This is in a separate drawer, and everything is marked over there. And that's why all this medicine, whichever pack they are having, this has got basically all the labels are also been differently color coded, so that you don't mix and match with the one medicine with the other. So basically, this, you have to just answer one thing. Remember, these are all these life-saving drugs along with the intubation tube and everything. Whatever you can have to just manage in the ward itself before the shifting to the patient to the ICU. So this is the card for saving the patient of the life at the ward itself when we cannot shift the patient immediately to the ICU.
Right, sir. Kanuji, sir.
Another one question, Gopal, you are asking when you are discussing the Thomas print, you forgot that.
Sir, sir, I also forgot that it was not really regarding Thomas Flint, sir.
Okay, I think everything has been covered by Gopa Kumar sir beautifully. All the questions. If somebody is listening to the class, he will definitely answer every question in the Viva.
Sir, sir.
Another question is there any difference in the usage of Crutchfield and Gardner-Well tongues, or it can be used anywhere and there? That is there any particular indication of Gardner-Well, any particular indication of Crutchfield, or where it cannot be applied like that?
I'm not aware of anything because each hospital, the hospital where I am working was using the cone tongues. Cone.
I think me and Subhrangshu all been both together been trained with only with the Crutchfield. So Subhrangshu might be remembering that we both together have put too many Crutchfield during our PG days.
But in Mumbai, I have not seen a crotch field. Everywhere it is garden wells.
Garden wells.
Yeah.
Yeah, garden
yeah.
well,
So
I
it's a
think you don't need to use a drill bit. You just need to
Just tighten it. Yeah.
rotate it
you
and
just
tighten it.
you just have to tighten it. You just have to.
Yeah.
Sir, I usually, while I was doing this spine surgery fellowship, we were told that whatever, either of these two, whichever you are going to use, you should know how to use it. And you can use it whichever you want. That's what I remember, sir. But
Quite-
auto stop
quite
or
right.
automatic stop at
No,
that 8
Gopal, your
millimeter.
voice is
We
not
lost
clear.
your voice.
Gopal, we could not listen to you. Some part of the
Yeah.
your
We lost
question
your
was
voice.
missing.
Sir, can you hear me now?
Yes.
Yeah, yeah.
Sir, my network is bit unstable, so that might be the reason. Sir, either garden well or crutch field, whichever you are using, you should not cross the inner table while applying it. That is important. And
No,
it is not. Yes, sir.
basically, Gopal, the simple answer for the student, basically what the examiner will be asking, they're happy to listen. Basically, there is a drill stop over there. The depth of the drill stop is 4 millimeter for the adults. Okay. So if you follow that depth stop, whatever Gopa Kumar sir was showing, that is
Guarded drill
only
bit.
that is a guarded drill bit with only 4 millimeter of length. So you cannot cross the inner table. Okay,
Sir.
basically, if you are reading very intricately, it has basically two depth. One is for the adolescent and the children, that is 3 millimeter. For the adult, it is 4 millimeter. But forget about this. Remember, 4 millimeter, it is universally used for the crutch field. That is a stopper that is affecting only 4 millimeter.
Right, sir. Thank you very much, sir. Kanoja, sir.
To all faculty, how many of us are using now USOL?
Usual, we are
sir.
not using. But
Because
in the
I have not
but
used, I think I have not used since last 20 years. Previously, we were having it.
No, diabetic foot, sir, I'm using it quite often.
yeah, but it is kept in the dressing trolley in the exam. You have to read it.
Secondly, as Dr. Kanuja has raised problem of or point of USOL, similarly, use of hydrogen peroxide. Nowadays, many of the surgeons are extremely against using hydrogen peroxide on any tissues because they say that it damages more than giving any benefit.
Actually, same question I was going to ask. I have written it.
Especially in those institutes where there are plastic surgeons working with orthopedic surgeons, the hydrogen peroxide bottles seen in the theater, the number of plastic surgeons become curious and they ask the bottle to be thrown out of the OT. They say that it damages the tissue so much that you should never use hydrogen peroxide in the wound.
Same thing regarding Vitadine. Sir, if you remember, we were in Tata Institute regarding this infection conference.
Yeah.
They were saying the dilution we are using is not effective. The dilution which is concentration which is required is very harmful.
Yeah.
For effectiveness. So
आज कालरा सर कुछ नहीं बोल रहे हैं सर का पेट्रोल
Very complete.
This is an electric vehicle today, sir.
सर मैं सबसे लास्ट में सर को बोलने वाला था ताकि फट से मैं बोलूं थैंक यू बोल दूं कालरा सर शिवानंद सर एंड कालरा सर
Tesla. So I have two comments to make, sir.
Yes,
sir.
One is that in DNB exam, this ground round makes the candidate can make the candidate fail or pass.
Yeah.
And those who approach the examiners, I tell you, it has happened when I was a coordinator. It many times. The examiner who wants to pass a candidate tries to make a difference in word round only. So he will give 30, 35 marks. Other will give 20, 22. You cannot make 15 marks difference. Then eyebrows are raised and average is marked. In my cases, in my examination center. So his 35 marks are made 22, I tell you. You cannot, I mean, everything is averaged.
Yeah.
Another thing I just want to tell you is nowadays, come today and go tomorrow is orthopedics. The days of traction and Thomas splint is gone. Wherever I have worked abroad, a patient hardly waits for a day. I tell you, he's operated on the day he comes on the night or maximum next day morning, whether it is a compound fracture or a closed fracture, whether it is all four bones are fractured, whether it is pelvis, anything. He is taken for surgery immediately or in the next day in the morning. So days of these splints and all this, although good for the exam, but they are gone. So that's all. Thank you
Thank you,
very
sir.
much.
Gopa Kumar sir, the another question which I wanted to ask you is regarding how much weight should be used for skin traction. I am asking this because few textbooks they are showing almost up to 15 pounds, sir.
15
So in
pounds,
exam, yes, sir, it is
Some
in
cases.
standard textbook, sir. It is
5
in
kg,
standard textbook.
even 5 pounds, 5 to 6 pounds, that is all, around 3 kg or 4 kg
Yeah.
you can use it. Yeah.
Normally,
Yes,
what
sir.
we use for skin traction is about 3 kgs.
Yeah.
Because anything more than that, I have seen the skin getting peeled off and
Peeled off.
forming blisters on the edges. So I think for a skin traction, 3 kgs is what is normally used and recommended.
Because sir, I am asking this question because this is distinctively student tell you, sir, this textbook says 15 pounds. So I have told 15 pounds. So I will request now all those senior actually examiners, what you think is the correct answer. And if standard textbook says 15 pounds, then is that correct? Gopa Kumar sir.
I don't think it is correct because you cannot give more than 3 kg, 3 pounds, that 3 kg, that is around 5.5 or 6 pounds.
Sir, Jain sir.
Gopal, which book they are quoting? If it is Stewart Hallett,
No, sir. Somebody
No,
has even, sir, even Rockwood they are quoting, sir.
no. Ideal for this is Stewart Hallett. Stewart Hallett says only 3 kgs.
Yeah.
Oh, right, sir. Right, sir. Because standard text they are saying, my
Standard
student
text is
only.
Stewart Hallett for skeletal
No,
traction.
no,
There is a
I
book
think,
on
I think,
traction.
we, I think we have to give the consensus on Stuart Hurley. So that is we have to follow for this, all this split and all this.
Yes.
Right, sir. Sir, I will request Jain, sir, to just make one message on our group, sir, because my own students told me कि सर बुक में ऐसा लिखा है यार आप 3 kg कैसा बोलते हैं. So I think this was the point actually I wanted to raise. Gopa Kumar sir, again, master of masters class, sir. We are really obliged and grateful that we are your students, sir. Again, clear, concept based, concise, concept clearing, and yet Gagar mein Sagar. Two more topics in a just 1.5 hour. We are really thankful to you, sir, from all students and from all faculties. We are really your students, sir. Thank you very much for such a academic feast for us. Thank you, sir.
Thank you.
Okay.
Thank you, sir. Thank you.
Thank you, sir.
Thank
Thank
you.
you, Gopa, sir.
Thank you, sir.
Good night.
Thank you.
Thank
Good
you.
night.
Thank you. Bye bye. Good night.
Kakatkar, sir. Shall I call off the day, sir?
Yes, yes.